So once again, Hodges has made a lovely summary for us. With that, what do we do first sort of question. So in the initial step, risk 1 is stratification. So the low risk are out of it. You've just given them their information and some support, and they're welcome to come back if they need to. But we're in the medium risk category now. And in the medium risk category, we will have this mixed pattern of psychosocial and the nociceptive drivers. So if you can see that they've got more nociceptive driver going on, there's detailed assessment of tissue loading and posture and movement, muscle activity, sensation, based on the movement system, and just a bit of a general assessment of pain cognitions and behaviours. But as time goes on, and if they're creeping into more neuropathic pain or centralised pain, then you've got to assess the relevance of neural tissue loading, their posture, their movement, their muscle activity, their neurodynamics in neuropathic pain. And in central sensitization pain, you've got an assessment of physical activity tolerance, because their lives are really changing by then. So if you can see the way that scale changes, it's actually quite an elegant way that you can start thinking in the clinic and subgrouping in the clinic. So detailed assessment guided by the pain mechanism group. And of course, they've all got education and reassurance to stay active. As we go down, the tailored physiotherapy would be much more in the nociceptive one of the motor control training, clinical reasoning, physical treatments, modifying biomechanics, and using manual therapy, and a bit of pain education and reassurance going on there. And you can see as the blue diminishes as you go towards the right, then the more the psychosocial management's coming into it. So we need to be able to assess these patients to subgroup them. The previous slide had the way to do that on it, what you should be looking at, and this is giving you the sliding scale of which way to go with different patients. Each patient is entitled to a really thorough assessment and clinical reasoning process. I very often get very chronic, persistent, failed back surgery, low patients in, and sometimes they are still in the nociceptive category. So you can't just assume that they've got neuropathic and central sensitization going on because they've had several failed back surgeries or they're coming back all the time. It could be just that those tissue loading issues haven't been addressed. And I would say that in most of my very complicated low back pain presentations that I'm doing a bit of everything. But I did sit down and have a think about my patients in relation to this graph, and it actually does slide like that. So he's done a brilliant job for an academic to putting that one together. And then, of course, down the bottom in the grey, we've got the tailored medical treatment. So people might need anti-inflammatory medication. They might need some injections. They might need some sort of ion channel blockers. They might need psychology. And it's just basically specialised psychological treatments are the call of not just you, but the team that you're working with. When you do get into more persistent low back pain, you should not be working on your own. You should have a team around you who can support you, multidisciplinary care, as we all know.